weeks after actually the pain initiated as well. And she had an MRI with a cyst running from splenoglenoid notch to suprascapular notch. I sent her first for a conservative treatment, EMG, and like neurological examination. She came back like 6 weeks after that. She had no pain anymore, but she still has some weakness there, like abduction, and but as I said, no pain. My question is, would you operate on her, even if she doesn't have any pain? She still has some weakness there. And there's another question I can ask afterwards, actually.
May I have the normal mic? That's easier.
Or you can have mine.
All right. So of course, this is a question on indication. This is much tougher. The slides I passed is, of course, about indication, when to go to, and where do not make any mistakes. The onset of a real nerve entrapment is very slowly, all right? So if it's a really entrapment, the pain and the aching pain that the patient has comes up very slowly. If you've got sudden pain, which is for a few days very tough, and then the pain goes away, you need to think about other pathology, which might be a Parsons-Turner syndrome, which is a completely different pathology. So the cyst might be a coincidental finding at that stage. So if the pain suddenly was there, I would be very careful to do operation.
She still has some weakness. That's the thing. And it speaks for suprascapular.
She can continue having weakness. If the pain was suddenly there, I would not go for surgery in her case.
Okay. And another thing, like you showed, like your approach to a cyst or a ganglion in a supraglenoid notch, like is that you go subacromially. Why not like go intra-articularly, just open it up and drain the cyst or the ganglion?
Yes, that's a very good question, and that is a possibility as well. It's been shown that if you've got a cyst like that because of a labrum lesion, it is normally enough to just repair the labrum. You even don't have to touch the cyst. It will disappear by itself. But on the other hand, if you leave it, the pain will be there until it resolves by itself. So as you're operating, in my hands, I would repair the labrum, but I would decompress and maybe even resect the cyst. And those patients immediately after surgery, their pain is gone. So there's two problems, is getting rid of their pain. And it's for the patient, it feels much better if you decompress it or even just decompress it or resect it. But scientifically, it would be enough just to repair the labrum. But if you're there, I would definitely decompress it. But you can discuss about it.
There's some studies where they didn't repair the labrum.
Sorry, we don't have to.
Okay.
Another question, please.
Yeah, I had a question regarding the same thing. How many times in your clinical practice you had an isolated suprascapular nerve release, apart from no cyst excision, no rotator cuff, no coracoid impingement, no subacrum, isolated suprascapular nerve release?
I'm doing 600 shoulder procedures a year, and probably we do 3 isolated nerve releases.
And what are the indications for those? Like isolated suprascapular nerve?
Yeah, that's where you go and you think this is really an entrapment of the nerve underneath that ligament, and it exists. So if you're after your setup and your clinical work and your technical investigations, then it does exist. It's proven, and you will see it, and then we go for it. It's rare, but you have to think about it. It exists, but it's rare, of course.
Another question, please. Yes.
I have a question for Dr. Davolkar. Where are you? Well, if you have a patient with an irreparable rotator cuff tear that undergoes a lower trap transfer, would you be concerned? What would you do regarding scapular kinesis?
I would definitely evaluate the various components of the scapula and see what movements are restricted or what movements with respect to which structures are affected, and based on which structure is affected, I'm going to deal with the treatment. So I'll use the Sermon's multi-system impairment analysis to find out which structures are at fault, which structures are tight, and accordingly, I'm going to rehabilitate this patient rather than thinking this is what should be the tailor-made program. I would rather wear my thinking cap and find which structures are at fault.
Yes, please. Please, finally.
I would like to ask about the scapula topics. Thank you very much. I have a question. What about high-level athletes that they have an asymptomatic scapular dyskinesis? Do you work on these patients, on
Yes.
these athletes?
Yes.
Do you think that this scapular dyskinesis is a problem in order to have an injury later? Do you
Yes.
prevent this scapular
Yes.
dyskinesis?
It's when we evaluate the scapula, we evaluate the scapular assistance test and we evaluate the scapular repositioning test. Along with the scapular assistance and the scapular repositioning test, we tell them to activate the kinetic chain, and we again see the effect of this, activating the core on the scapular muscle strengths through the analysis of handheld dynamometers, and then we find out whether the fault also can be lying at the core, and we try to recruit the core muscles.
This question is because in Greece we have a lady, she's number 20 in the ATP world. She plays high-level tennis, and
Yeah.
she has some kind of asymptomatic scapular dyskinesis, asymptomatic. So would you like to work on this lady during the season?
Of course, yes.
Yeah, okay.
And there is data, I've showed the data, there's data out there that these athletes, not patients, they have an increased risk for developing shoulder problems. So it's a prevention thing you do with them. It's not a treatment, but if she is doing high-level sports and she has a dyskinesia, you have to think about it that might be a risk factor for later problems.
Other questions? Kyria Peta.
Just to add something, a comment. Perhaps this kind of patients are not patients, this kind of athletes with asymptomatic dyskinesis, perhaps they need more focus of exercise program, prevention exercise program on core stabilization. Because core stabilization is the basis for the next problem, probably. So you have no to correct something asymptomatic, but you have to focus on the core of this athlete.
That is a perfect point. I mean, that was what I tried to tell in my talk. You have this scapular dyskinesia, which you see, it might be due to that she has a certain amount of GERD. It might be due to that she has an insufficient core. It might be due to that her hip abductor are not working properly. You have to check that. When we talk about going for that scapular dyskinesia, I mean, it's the next step to check, as he exactly told. I have to look where is this deficit, and then I have to train for that. But that's exactly the point we tried to make, that it's not just the scapula and just the serratus you go to with this lady we are talking about. It's you have to check her, you have to check around, and then you go for the GERD or you go for the hips or wherever.
I have a question to all the speakers about the shoulder position. What is the best shoulder position to avoid overhead athletic injuries? Because the first description about zero position of the shoulder was from India, Dr. Saha. Saha was the one who described the zero position of the shoulder, and that was supposed to be one of the best position where you don't get any shoulder injuries. So if in your clinical practice, what is the best shoulder position to avoid the shoulder injuries?
No, you should avoid flexion internal rotation, because that's more of an injuring movement. And you should enhance and try to work on the movements in the scaption plane at an early stage. Scaption plane is 90-degree abduction, 30-degree forward flexion. So most of the movements which we do are in the scaption plane and not in the pure coronal or sagittal planes. So you should work on the in the scaption plane. There is also a concept of open pack and closed pack position of the shoulder, but that's more related to the assessment and treatment related to manual therapy in shoulder.
Okay, I think that we have to finish here. Thank you all the speakers and the participants. We see you tomorrow.